You know, we're recreational legal. We just don't have an infrastructure yet, so understand. All right, great to see you today. Of course, the familiar face, Dr. Jonathan Javitt, who is the founder, director, and chairman of the board of this little company called NRX Pharmaceuticals. Great to see you. How are you, sir?
It's wonderful to see you.
You're starting to be sort of a member of the cast. You've been here so long.
Big time.
And now there's a Bizumentary coming out. Of course, we have a trademarked documentary called a Bizumentary, which is basically about Jonathan's space that the network wanted to do and give the opportunity to get some exposure for you guys. And we're going to be able to see that on BizTV as well as the other networks here coming on very shortly. And you'll see it pretty on a high rotation here for the next 9 months. But it's great to see you. And there's lots of stuff to talk about. And then we're going to spend a few segments talking to you. And of course, you have a couple of guests we brought on. Of course, Mike Taylor, our investment banking expert, is going to be with us as well. And of course, coming up later in the program, Dr. David Feifel. And I'll let you explain who he is. But let's talk about ketamine. We've been talking about that ever since we met you. Ketamine being sort of aimed for the standard of care for suicidal ideation and a number of other things. My question for you is, if ketamine is going to be the standard of care, then why the heck hasn't the FDA approved it yet? Or why has anybody brought it up before?
Well, you know, it's a great question. And in fact, on next Thursday, the Reagan-Udall Foundation in Washington is hosting an all-day conference on exactly that question with the FDA, with the public stakeholders. But the short answer to the question...
Nobody asked nicely.
Nobody asked at all. Now, that's not exactly true. Johnson & Johnson did ask and did get approval for a nasal form of ketamine, and that's used in some patients. But most doctors want to be using the intravenous ketamine, and nobody's asked.
Real quickly, because you talked about this at the very beginning when we talked to you. Talk to us about the difference between the nasal, the oral, and the intravenous, as far as efficacy and safety and so on and so forth.
So as far as oral ketamine goes, nobody knows. It's the Wild West, and the Drug Enforcement Administration has shut down the guy who was mailing homemade oral ketamine around the country and telling patients to use it.
Probably a good idea that he said.
Probably a good idea. Probably drugs that are used in the United States should be proven to be safe and effective for their intended use and not to be abusable. So nasal ketamine and intravenous ketamine achieve similar things. They get ketamine into the bloodstream. Now, if you do it with a needle in an IV bag, you know exactly how much ketamine is going into the bloodstream, and you can achieve a steady state dose. If you administer ketamine through the nose, then you're giving a blast of ketamine, you're getting a sharp spike, and then you're getting a downdraft, so you have to keep giving nasal sprays up to 6 times an hour to maintain that steady dose. And the anatomy of the nose has a tremendous amount. You know, some people have these turbinates that stick into the middle of their airway that diverts the ketamine down the back of your throat into your stomach. So the pharmacology of nasal ketamine is much less regularized than the pharmacology of intravenous ketamine.
You talk about multiple doses in nasal ketamine. It brings up the question about how many doses at all. So when we talk about intravenous ketamine and as a treatment, is this something that would happen once a week? Is it once a month? Is it as needed?
Well, it's a great question. We know that the pharmacologic effect of ketamine wears off between 3 and 5 days. Now, does that mean that somebody's going to immediately have a recurrence of depression or recurrence of suicidality? That's a very individual thing.
And is there an endpoint, by the way, to treatment at that point, right?
And that, too, is a very individual thing. Bipolar depression, which is the form of depression that's most likely to be associated with suicide. You know, think Matthew Perry, Robin Williams,
Sure.
Kate Spade, Anthony Bourdain. That's an episodic disease where, you know, most people thought of Robin Williams as sort of a manic guy. They used to call it manic depression.
Right.
These are people who are the brightest light in the room. But when they get depressed, it's lethal. In fact, if you know 2 people with bipolar depression, you have one of those 2 people is probably going to try to kill themselves over the course of their lifetime. If you know 5 people with bipolar depression, one of them is going to succeed. Whereas what they call major depressive disorder or unipolar depression, you have people whose life goes between okay and pretty sad, and those people are actually much less likely to harm themselves.
No kidding. The name of the company, by the way, NRX Pharmaceuticals, they're publicly traded. NRXP is a stock symbol, NRXP. We've got Dr. Jonathan Javitt here.
It's time to wake up. It's an average morning in America. 333 million people waking up to start their day. A day much like any other across the globe. At the time of this recording, by the end of the day, an average of 10,000 new Americans will have been born. About 12,000 Americans will get married, and around 58 million of them will fight some battle with mental illness. The number that's concerning, by the time the sun goes down, 132 of them will lose that fight.
There's so many variables as to what causes depression, but such a giant number of people suffer from depression.
And that's, by the way, how you assess someone for suicidality, because depressed people, lots of people get depressed, will have suicidal thoughts, and they're far from rare. And
join us as we take a look at a mounting crisis from the history.
You guys, just under 50,000 Americans died by suicide last year. That is thought to be the highest rate since the dawn of World War II.
The U.S. Surgeon General calls it the defining public health crisis of our time. In 2021, more than 12 million American adults thought about suicide. 1.7 million attempted it.
To the experts.
What about this disease, bipolar depression, that can take an incredibly productive, engaged, intelligent, brightest light in the room kind of person and kill him within 2 weeks?
I used to tell, colleagues that I feel like we're being sent out every day to fight Godzilla with a pea shooter.
I think we need to think of suicidal ideation as a risk factor for suicide and really focus on treating suicidal ideation.
To the unlikely hero on the FDA's horizon.
Ketamine's not a new drug. It's been around for 70 years. Well, the problem is, for 70 years, it's been labeled as an anesthetic. It's never had any label from the FDA for anything related to treating depression or suicidality.
It is difficult when you're in that space to even fathom that there's someone there that can help you or has been through that before.
And so you're having to unlearn years of training and years of, pressure to not show weakness, to then turn around and say, look, I'm having a problem.
That's what I mean when I say we don't, as a culture, people don't teach us how to ask for help and then receive help.
Each number, not just a statistic, but a story left unfinished. A conversation cut short. In the hustle and bustle of our daily lives, amidst the milestones and the mishaps, countless Americans are fighting an internal war. It's a battle that unfolds in silence. Its impact, profound, touching more lives than we might have ever realized. But much like a biological disease, mental illness takes many forms. And also, like many diseases, some are more lethal than others. What are we doing to confront these demons? Is it enough? And crucially, what more can we do to win the nation's fight against the growing plague of suicide?
Depression is usually kind of a deep hole that somebody finds himself in. So most people don't make the decision consciously to say, I'm depressed. They don't realize what it is. I mean, I personally was going to a doctor, a psychiatrist for my depression.
And anhedonia. And anhedonia is basically inability to experience pleasure or joy.
It won't take you long online to find plenty of definitions and explanations for what drives a person to attempt suicide. C.S. Lewis said on the subject, mental pain is less dramatic than physical pain, but it is more common and also more hard to bear. The frequent attempt to conceal mental pain increases the burden. It's easier to say, my tooth is aching, than to say, my heart is broken.
Patients that have very severe psychiatric illness like schizophrenia, bipolar disorder, they're at high risk. Patients that are using a lot of substances like alcohol, they're at high risk too.
People with bipolar depression who are most likely to commit suicide. If you know 2 people with bipolar depression, one of them is going to attempt suicide at some point in their lives. If you know 5 people with bipolar depression, tragically, one of them is going to succeed. This is a disease that strikes the best and the brightest among us, the brightest light in the room, and can kill people suddenly and shockingly, quicker and more certainly than any cancer.
MayoClinic.org states, bipolar disorder, formerly called manic depression, is a mental health condition that causes extreme mood swings that include emotional highs, mania or hypomania, and lows, also known as depression. When you become depressed, you may feel sad or hopeless and lose interest or pleasure in most activities. When your mood shifts to mania or hypomania, less extreme than mania, you may feel euphoric, full of energy, or unusually irritable. These mood swings can affect sleep, energy, activity, judgment, behavior, and the ability to think clearly. But first, let's start with what regular depression is so we don't get confused.
So we don't have a clear understanding of what's happening in the brain in depression. There's a lot of evidence mounting to suggest that changes in cortical inhibition and changes in connectivity between different brain regions are affected in depression. It's hard to define. It's a heterogeneous sort of concept. We classically use the DSM, the Diagnostic Statistical Manual, edition 5, to kind of think about the ways that we like to classify it.
Diagnostics and Statistical Manual of Mental Disorders, DSM, is the handbook used by healthcare professionals in the United States and much of the world as the authoritative guide to the diagnosis of mental disorders. The DSM currently lists the symptoms for depression as a depressed mood, loss of interest or pleasure, weight loss or gain, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, feeling worthless or excessive inappropriate guilt, and decreased concentration. It's important to note that, according to the DSM, a diagnosis of depression requires the presence of either a depressed mood or a loss of interest or pleasure, the first two symptoms, along with at least 3 other symptoms. Dr. Wiseman emphasizes the critical role these primary symptoms play in accurately diagnosing depression.
When someone has 5 of 8 symptoms within that diagnosed definition of depression, then they, by definition, have depression. It's one of the leading causes of disability around the world. In the US alone, about 10 million people or so experience depression.
Of these people experiencing depression, those with bipolar are at the greatest risk of death. However, due to the way the disease manifests, many people go years without a proper diagnosis.
Most manic episodes precede depression, not the other way around, meaning it'll usually first be the mania. So they go from a place of never having a depressive episode or anything that would be considered like really a pathological mood episode that lasting to the first abnormality being mania, and then they go into a depression. That is the more classic pattern, mania and depression. Now, as time goes on, there's more just the depression on its own.
Being in a depressed state is an inherently human condition on its own and can lead to dark places for those not just with bipolar disease either.
Or actually, I went to boot camp December 29th, 2009, and by October, we were heading to Iraq. And then I got injured in Iraq, ended up losing a lung. All of a sudden, everything went crashing down. I didn't have my health anymore, didn't have, the accolades anymore, and then to come back to the stateside, and I felt like I didn't have a purpose anymore.
It's not just your bad day or you're feeling sad or you're feeling low a couple of days. It's over a period of weeks at a time, or even longer sometimes for some folks, to where they really cannot bring up their mood. And so they're struggling with not being able to get joy from the things that normally bring them pleasure. They're feeling hopeless for their future. They're feeling worthless. They're struggling with feeling guilty.
When I lost interest in doing things like riding my motorcycle, I lost interest in, having relationships with girlfriends and having relationships with friends and going out and even seeing the ocean. I didn't want to step out my door and see waves, and I didn't want to see dogs. I'm like, who doesn't want to see dogs?
And a lot of times people who have depression really struggle with suicide and wanting to not be alive anymore. Whether that's explicit thoughts about wanting to die by suicide or something more like not wanting to wake up in the morning.
Depression is one of the major indicators And I think entrees are the portal of, the suicide ideations. Because when you get depressed and you can't feel better, you want to do something to fix it.
One of the great national tragedies is we continue to lose 22 veterans and active duty personnel to suicide every day. We've lost more troops and veterans to suicide than we've lost to combat in all the wars fought in the history of the United States.
Since I've eaten anything, it's been a week since I talked to somebody. It took handfuls of painkillers, and also I was in off and on with a relationship with someone that was a cutter. Like, all right, well, if you're cutting, I'm gonna cut too, and slice my arm up real good.
It seems like we're going backwards. I mean, there are 22 veterans every day that commit suicide. That's over 8,000 estimated. 22 veterans a day. That's over 8,030 people annually that are taken from us. And if you look at that under any other demographic, it's a big deal. I mean, those are massive numbers of people that are no longer with us.
And of course, that's just the tip of the iceberg. 3.4 million Americans every year make an active plan to kill themselves. 1.7 million Americans every year actually try to. And they say 50,000 people a year die of suicide in the United States. We know that's the tip of the iceberg. We know that the majority of people who die by suicide, it's unreported.
I had a week of blackouts, and then that was the day that I woke up my last day and everything was a mess. And that was the day that I was in a guy's office, and we talked about this before, and I was prepared to jump out the window. I was on the windowsill, I was ready to go. And it was my mother's voice who said, suicide is selfish.
One of my closest friends, Mitchell Max, man who was at the very top of his class in Yale College, very top of his class in Harvard Medical School, came to me in 2009 and said he was having an episode of depression and just wanted me to be involved, wanted me to sort of be part of his team. I said, well, okay, Mitchell, you and I both know that this is nothing to trifle with. This is a disease that can be lethal. What are you going to do about it? He said, well, I'm going to go see the chairman of psychiatry at my university. Well, when are you going to see him? I'm going to see him on Tuesday. Will you call me after you see him? Yeah, I'm going to call you. Calls me up, says, the guy really understands me. He says I'm going to be fine. He gave me some Zoloft. He's going to see me in a couple weeks, but I'm not worried. So he winds up seeing the junior guy in the department who says, this Zoloft isn't working as fast as we'd like. Why don't we triple the dose and see what happens? Well, if you read the label on Zoloft, it says, caution, this drug may cause suicide. And sure enough, Mitchell goes home and hangs himself. And that's probably the most shocking moment of my life. It's probably the biggest surprise I've ever had in my life as a physician.
Like an organ like the kidney or even a complex organ like the heart, they're nothing in terms of comparison to the brain and the mind. I mean, we are still struggling at a very rudimentary level to try to understand how people's subjective feelings and the way they think can possibly be can emerge from a 3.5 pound piece of tissue with wires in it. It's just mind-boggling. But nevertheless,
the worst side effect from mental illness is the total loss of one's natural instinct for self-preservation, our very will to live. But from the ancient Greek tales of Lucretia to the star-crossed lover's fate of Romeo and Juliet, or even to the more modern, teen-spirited tragedies of people like Kurt Cobain or Robin Williams, mental illness and suicidal ideation are nothing new to the human condition.
Oh, you mean like croquet? Croquet!
In fact, the list of people you've probably heard of that face their own battles with mental illness and suicidal thoughts is longer than you may think.
It is for us, the living, Brad. It's to be dedicated here to the unfinished work, which they who fought here have thus far so nobly advanced.
Abraham Lincoln long battled mental episodes that often led him to think of suicide. The playwright, Tennessee Williams, documented his struggles with manic depressive states in his memoirs. Virginia Woolf, the famous British novelist, Vincent van Gogh, Beethoven, Charles Dickens, they all had their own internal wars with either depression or mania. It was only until fairly recently did we even understand bipolar disorder as separate from depression. Even Sir Isaac Newton was documented as having symptoms of what was known back then as melancholia. But where did our first understanding of all this start? And how much has changed since the past and how we treat this?
In the early days, folks who were experiencing depression were labeled as something maybe that they weren't. They thought something was going on with this person, but they didn't really have a clue that it was this person is just depressed.
In the 5th century, the Greek physician Hippocrates proposed that depression, then known as melancholia, originated from an imbalance of the body's 4 fluids or humors: yellow bile, black bile, phlegm, and blood. He particularly associated melancholia with an excess of black bile in the spleen. His remedies included bloodletting, baths, physical exercise, and dietary changes. On the other hand, Cicero, a Roman philosopher and statesman, held a different view. He argued that melancholia stemmed from psychological factors such as anger, fear, and sadness. A prevalent belief among many, including the educated Romans, was that mental ailments were caused by demonic forces, or the wrath of the gods.
Our theories have progressed. I think once we were able to identify sort of the brain, and you think it's obvious to us now, but it took many centuries before the brain was sort of identified as the focal point of emotions and thinking.
In the Middle Ages, mental health was heavily influenced by Christian beliefs in Europe, attributing mental disorders to demonic forces once again. This led to practices like exorcisms, and in harsher scenarios, drowning or burning the afflicted. Many were confined to what were then called lunatic asylums.
And to alarmingly recent history, folks were institutionalized against their will for sometimes their whole life. And it was largely due to the fact that we didn't know what to do with them. We didn't know how to help somebody who was struggling with depression because the research wasn't there. The knowledge wasn't there of effective ways of managing depression and helping somebody who's struggling with depression.
In the 18th and 19th centuries, or as we know it, the Enlightenment Age, melancholia was often seen as an unchangeable character flaw, believed to be hereditary. This perspective led to continued outcasting and institutionalization. As the Enlightenment Age continued, various theories emerged about depression's origins, ranging from internal conflicts between desire and moral understandings to searches for physiological reasons behind the disorder. Unique treatments of the era included prolonged submersion in water, using a spinning stool to supposedly reorient the brain, along with dietary changes, enemas, horseback riding, and induced vomiting. Benjamin Franklin even experimented with an early prototype of electroshock therapy during the time, which, believe it or not, is still a treatment used for treating bipolar depression today.
So ECT, electroconvulsive therapy, is a treatment with a lot of stigma, but we do it a lot now in the clinic. It works quite well. It's the most effective treatment we have. It's probably the most effective treatment for suicide prevention in terms of psychiatric practice.
Probably identify the first era of modern psychiatry at probably around the turn of the 20th century, the early 1900s, with Sigmund Freud coming up with the ideas of different pressures and different psychological structures within the mind. He understood that the brain, he was a trained neurologist, so he understood that the brain probably was at the root of this, but he understood also that our technology wasn't at the point where we could directly modify the brain, although he did expect in the future that we'd be able to do that.
While talk therapy, also known as psychotherapy, has its roots in ancient times, its modern form was pioneered by Sigmund Freud. Freud believed that talking about one's thoughts and feelings could uncover hidden, unconscious conflicts influencing behavior. Freud's approach involved free association, where patients spoke freely about whatever came to mind, allowing therapists to interpret and uncover deep-seated issues. This marked a significant shift from physical treatments of mental illness common at the time.
In the interim, he came up with a sort of a theory and a corresponding treatment to alleviate things like depression and neuroticism by talking to people and changing their brains in a way that way, because he also understood that every time anybody experiences anything, including every time we interact with somebody, it changes our brain.
In the early 20th century, Carl Jung, a Swiss psychiatrist and former student of Freud, expanded on these ideas, integrating concepts of collective unconscious and archetypes. Around the same time, American psychologist Carl Rogers developed client-centered therapy, emphasizing empathy and unconditional positive regard. These pioneers laid the foundation for various therapeutic approaches we use today, from cognitive behavioral therapy to mindfulness-based therapies, demonstrating the enduring power of talk as a tool for healing and self-discovery.
And we really didn't have a very good understanding of what it was, and so someone was just labeled as hysterical, and they were placed in some kind of institution or placed on some kind of heavy-duty meds, or they were given electroconvulsive therapy, and those things didn't help them because that's not what they needed. They needed somebody to really understand what they were going through and more advanced ways of helping them.
And while Freud and Jung were pioneering therapy through the power of conversation, medicinal breakthroughs were on the horizon, offering new and innovative options for treatment.
Is this the way you feel in the morning? Still tired after a good night's sleep? Too dragged out and nervous to face the day? Pain mounts up. You feel dull, depressed. Tension puts nerves on edge.
The pharmacological journey began in the 1950s, a pivotal decade for psychopharmacology, which is a fancy way of saying medicine for the mind. In 1952, a major breakthrough occurred with the discovery of chlorpromazine, marketed as Thorazine. Originally developed as an anesthetic, it was found to have powerful effects on psychotic symptoms, leading to its widespread use in treating schizophrenia and other severe mental disorders. This marked the beginning of the antipsychotic era. Shortly after, in 1957, the first antidepressant was discovered, iproniazid. Initially developed to treat tuberculosis, was found to elevate mood and alleviate depression. This led to the development of the monoamine oxidase inhibitors, MAOIs, and later tricyclic antidepressants like imipramine, which became a cornerstone in treating depression. The 1960s saw the advent of benzodiazepines, with diazepam, commonly known as Valium, becoming a popular treatment for anxiety and insomnia due to its calming effects. Benzodiazepines offered a safer alternative to the barbiturates previously used for these conditions.
Valium works promptly to relieve excessive anxiety and apprehension. Side effects other than drowsiness, fatigue, and ataxia are rarely encountered.
In the 70s and 80s, mood stabilizers like lithium became widely recognized for their effectiveness in managing bipolar disorder, helping to stabilize mood swings and prevent manic and depressive episodes. The late 1980s introduced a new class of antidepressants, the selective serotonin reuptake inhibitors, SSRIs, with fluoxetine, known as Prozac, leading the charge.
Yep, I was on Prozac for a long time, and I'm not sure. It may have helped me out of a jam for a little bit, but people stay on it forever. You know, I had to get off at a certain point.
While SSRIs provided a more targeted approach to treating depression and anxiety with fewer side effects compared to older medications, they were not without risk. For some individuals, particularly younger patients, SSRIs have been associated with an increased risk of suicidal thoughts and behaviors.
We're kind of back where we started, aren't we? So we're back where we started from.
Not exactly. While we've come a long way since the days of bloodletting, and we've definitely made medications and new advancements that have helped many people, we're still just barely scratching the surface on what we know. Today, psychiatric drugs continue to evolve, with ongoing research into novel treatments like psychedelics such as psilocybin and MDMA, showing promise in clinical trials for various mental health conditions. And also, ketamine for rapid relief of severe depression.
Well, let's talk about ketamine. Ketamine is an anesthetic. It was actually developed by the US Army in the Korean War as a battlefield anesthetic that would induce rapid relief from pain without causing respiratory suppression, without creating a risk that somebody would stop breathing and need a tube put down their throat, because a combat medic in a battlefield is not really in a position to intubate somebody. That's the origin of ketamine. And it's been used as an anesthetic for 70 years. Veterinarians love it. My dogs get ketamine when they get their teeth cleaned. Well, it turns out that ketamine also has both a euphoric effect, and it's become a party drug, but it also has a very potent antidepressant effect. The way that was discovered was a scientist named Rob Berman at Yale was giving ketamine to patients because it was already known to be an NMDA antagonist.
So the NMDA receptor is a specific kind of receptor in the brain. It's activated by a activating compound in the brain called glutamate. And so it's excitatory. When glutamate kind of binds with NMDA, it leads to activation of specific neurons and brain cells. And so this is important when we talk about the action of ketamine and S-ketamine and all the other forms of ketamine, because we think a primary mode of action is by blocking that receptor.
To this day, we know that all of these drugs that are on the market for depression, they call them SSRIs, SNRIs, they all raise serotonin levels in the brain one way or another, but nobody knows exactly how serotonin works at a biological level. Well, we do know how the NMDA channel and NMDA antagonist drugs work at a biological level.
So by blocking the NMDA receptor, it's a key piece of the mechanism of action of ketamine and ketamine analogs. And we know that ketamine is historically a dissociative anesthetic. That's what it was originally intended to be used for. And only recently has it been studied specifically in depression, because doctors basically found that patients undergoing anesthesia were improving in terms of their depression.
So ketamine has been a game changer for treating depression. The truth is, with further exploration after the initial, recognition of ketamine's tremendous benefit, we see now that it also helps the depression that people with bipolar disorder suffer from so frequently. And what's interesting is that in general, there's a kind of a concept that the stronger something has the ability to improve depression in somebody who, for example, with major depression, who doesn't have that proclivity towards mania, that same treatment becomes an increased risk when given to somebody with bipolar disorder, because an antidepressant in somebody who has the capacity to have moods that go abnormal in both directions could destabilize them, and we don't see that. We see it probably less than, certainly not more than, the standard antidepressants that we've known have that propensity to destabilize somebody whose depression is of the bipolar disorder type of depression.
Psychologically, there's a lot of questions of whether being dissociated, seeing yourself from the outside, thinking about your thoughts from the outside could be something that's useful to treat depression and maybe
This started because we submitted a drug application to the FDA, an investigational new drug application, saying that we wanted to test our pill, D-cycloserine lorazepam, which hopefully will be approved as a safe oral home use pill. D-cycloserine is a different NMDA antagonist from ketamine. Think of ketamine as putting a cork in that pipe in the brain, whereas D-cycloserine is more like turning a faucet. So we went to FDA with that program, and they said, yes, but you're using ketamine to stabilize some of the most suicidal patients before you put them on your pill. We think you need an investigational new drug application for ketamine. We assumed at the time that somebody else was really going to develop ketamine and bring it to market, because there were a couple of companies already doing it. Johnson & Johnson's developed a nasal form of a variant of ketamine, but they surprised us when they said, well, people with bipolar depression can't use this medicine, only people with major depression. Well, the problem with that is it's the people with bipolar depression who are most likely to commit suicide. This is a drug that can turn off thoughts of suicide within hours. This is a drug that can have a marked reduction in symptoms of depression within hours. It's at least as good as, and probably better than, electroshock therapy, and acts far more rapidly. So while there are things about ketamine that we need to be very cautious about, on balance, we're talking about a life-saving drug.
From ancient techniques to talk therapy to electroshock therapy, all the way to new medications and antidepressants, the growing epidemic of suicidality remains an issue that'll face Americans for years to come. But with new answers and solutions on the way, there's still hope.
I think we need to think of suicidal ideation as a risk factor for suicide and really focus on treating suicidal ideation. And so looking at that as sort of the target, the diagnosis to treat, which if you can kind of scale that across a country and reduce that overall in a population, then hopefully you'll reduce suicide as well. And you likely will, because it's a very strong risk factor.
Six years later, it was replicated, and I said, I'm still skeptical, but I'm so desperate. What if it's half as good as these studies? So I went to UCSD, the powers that be, and said, I want to give my patients with depression.
When you talk about desperation, are you desperate because you're losing patients to suicide, or
you're seeing veteran numbers? You're seeing the same numbers we're seeing, or is it something different?
Look, you do lose people. But even when you don't lose people, you lose people.
Sure.
Because when somebody lives with depression, they may be alive, but they're
not really sometimes. Right?
It's gone.
They're really not.
His name is Dr. David Feifel. He is the Professor Emeritus of Psychiatry at University of California, San Diego. So the question is, clinic-wise, and it kind of goes into a two-part question for the two of you, and then of course there's investor will and investor accreditation when you talk about investors being interested in this, which is why I've got you all three here. Is this a nationwide type thing? Do you put these in every city? Do you make it a destination point for, as they have some cancer treatment centers across the country, or do you make this with every area of dominant influence in the United States, in which there's 16 of them, to where you don't have to go far to get? What's the ultimate goal for you?
I think the ultimate goal, yes, is everyone having access, and everyone being able to, without too much inconvenience, being able to go and get this remarkable treatment.
Mike, you and I have worked on a ton of deals together, because everybody knows in my other life, I'm an investment banker and run a venture fund and a couple of other hedge funds. And you and I, when we first talked about this as something to take a look at, neither of us were, other than, looking at this company as a publicly traded company that had a long way to go, got emotionally involved in this thing. And suddenly we see this political will with investors that you talk to as you represent billions of dollars of family office money. What's been the tipping point when you're talking to people, and for you specifically, when we're talking about Hope Therapeutics, which I'll let Jonathan explain in just 1 second, but talk about that part of it.
Yeah, I think what we've started to see is that from a business standpoint, obviously, unfortunately, there's a very large market. And the ketamine clinics, I think, what we're trying to do with Hope Therapeutics is to really build out a viable place that's medically backed for people to go who are struggling, suicidal ideations or feelings of.
And it doesn't exist now.
It doesn't exist.
And there's not a, not to mention there's not
too many clinics are confused with med spas that do ketamine on Monday and vitamin B on Tuesday. And
that's a typical week for Mike, except for the ketamine. Well, that massage on Wednesday.
It's donuts on Monday.
Okay, there you go.
Yeah.
But I mean, the point is, if you take this nationwide under the banner of Hope Therapeutics, which we've talked about before, talk about what that looks like.
So, our objective is to think of DaVita. If you're a patient who needs dialysis, you know that you can walk into any DaVita clinic anywhere in the United States and get reliable care according to protocols that everybody understands with a quality that everybody understands. And right now, ketamine clinics are the Wild West. You've got some highly credible clinics that are led by psychiatrists, where not only are they treating people with the drug, but they've got a whole therapeutic environment built around it so that they know that these people who have real risk of self-harm are safe. And then you've got a bunch of people who heard about it, who are hanging out a sign, who may not have any real training in psychiatry at all, who are just slinging ketamine without FDA approval, without being under any kind of safety umbrella. And people are reading about some unfortunate happenings as a result. So the objective is to build a national brand that people can rely on, that the FDA can trust, that the regulators can trust, that the insurers can trust.
And the investors can trust as well, correct?
Yeah, because right now the alternative for people with suicidal depression is electroshock therapy.
Dr. Feifel, what's the connection point here? What's the last mile solution to get us there, in your opinion?
I think Jonathan pointed out a lot of the needs. That is to bring something that right now is very unregulated, non-standardized, to weed out some of the bad players, to get the quality up a little bit more standardized, so that anyone can go to a place and know that this is going to be done the right way. Right now, that's not the case.